Hello, thank you. My name is Pamela Palazzari. I'm a healthcare consultant with Milliman, and we're going to give a presentation today about a study that was recently commissioned by COA about the cost drivers of cancer care. So the study is on the cost drivers of cancer care from 2004 through 2014 in both the Medicare and commercially insured populations. So I'm going to go through the objective of the study, as well as some notes on the design and methodology. And then we'll talk about 3 sections of key results. And after each section of results, we'll have some discussion from the other panelists. So our study objectives were using data from 2004 through 2014 in both the Medicare and commercially insured populations. We set out to identify trends in the overall cost of cancer care, as well as trends in the component costs of cancer care, and to create comparisons between those trends in the costs for actively treated cancer patients and for non-cancer patients. So thinking about what is the difference between those populations. We did this using data for 11 years, from 2004 to 2014. We used 2 data sets. One is the Medicare 5% sample, which has all Medicare claims for 5% of Medicare beneficiaries, excluding pharmacy claims, and this is only Medicare fee-for-service beneficiaries, not Medicare Advantage beneficiaries. We also used a commercial claims database called the Truven Health Analytics Market Scan database, and that includes all paid medical and pharmacy claims for between 15 and 50 million commercially insured lives each year. So it's worth noting that that number did change by year, but we felt that 15 million, which is the lowest year in question, was a sufficient sample size for this study. What we did is we went through each calendar year separately, and we identified all cancer patients within that year based on their diagnosis coding. We then identified the subset of cancer patients who were being actively treated. So active treatment was defined as either chemotherapy, radiation therapy, or cancer-directed surgery, and we looked for codes for any of those procedures to identify a patient as an actively treated cancer patient within that calendar year. Then we identified some characteristics of each of these populations, and we divided the costs of each of the populations by major service categories. So all of the figures and tables you'll see are based on this study design and methodology. So our first section of results is about the population level dynamics. So the first finding that we're going to talk about today is that cancer prevalence has increased over the 11 years, and the increase is mainly in the non-actively treated population. So in these graphs, the one on the left is for the Medicare population, and on the right is for the commercial population. What you're seeing is that the green section, which is the actively treated cancer population, is relatively stable. But the blue section of the bar, which is non-actively treated cancer patients, is increasing. So in the Medicare population, cancer prevalence increased from 7.3 to 8.5%, which is a 16% increase. And in the commercial population, it increased from 0.7 to 0.9%, which is a 26% increase. So the next finding is about per patient costs. So these graphs demonstrate per patient costs in 4 populations: the total population, which includes all patients in the sample, the actively treated cancer population, the non-cancer population, and that non-actively treated cancer population. So those were 4 distinct populations. And what we found, again, the top is Medicare and the bottom is commercial, is that the increases in those 4 populations were relatively similar. So even if you can't see the numbers exactly on these graphs, you can tell that the bars aren't that different. What we found is that for Medicare, the total population was trending at 35.2%, the actively treated cancer population at 36.4%, and the non-cancer population at 34.8% respectively. For commercial, those numbers were higher, but they were similar: 62.9%, 62.5%, and 60.8% respectively. We did test this finding because we found it somewhat surprising, right? We didn't necessarily anticipate that the change in cost for these populations was going to be so similar throughout the study period. So we tested this using 95% confidence intervals, and what we found is that the 11-year cost trends between those 3 populations were not statistically different. I think one of the last findings in this section is about the contributions to total spending by cancer patients. So when we think about out of the total spending for Medicare or for the commercially insured population, what percentage of that spending is attributable to cancer patients? In the Medicare fee-for-service population, we found the contribution to total population spending had increased over the 11-year period from 19.5% to 20.8%, which is a 6.7% increase. And in the commercial population, we found that the contribution increased from 9.4% to 10.7%, which is a 13.8% increase. And so we copied some of those numbers onto this slide so you can compare more easily. In the Medicare population, recall the prevalence of cancer increased by 16%, but the contribution of those patients to total spending only increased by 6.7% over the same period of time. And in the commercial population, again, we saw a 26% increase in the prevalence of cancer, but only a 13.8% increase in terms of how much spending those patients contributed to the total population spending. So we'll pause here for commentary.
Thanks, Pamela. So I think that in the first portion of this study, as we look at total cost, I think there's no one in this room that isn't concerned about the cost of cancer care. But that narrative has often gone that the cost of cancer care is outpacing the cost of other healthcare resource utilization in total. And what we can see from this information, looking at both the Medicare and a commercial population, is that's not a statement that's fact-based here. What we can see is while cancer spending has gone up for actively treated cancer population, cancer patients, and patients that are not actively treated with cancer, that growth in spending is proportional to total healthcare resource utilization. Not only is it proportional to total healthcare resource utilization, but this is during a time where cancer prevalence has increased in both populations. So I think that stands counter to sort of what we hear so much about the costs of cancer rising as a disproportionate rate, which is not to trivialize the fact that the costs of cancer are rising. But again, it's useful to understand that that's a proportional change.
Thank you. So, for me, this study, was important for, or the purpose of the study was important for a couple of reasons. First is that, the oncologists in the audience here, you've been asked to change what you've been doing for many, many years. How you prescribe therapy, how you take care of patients, where you take care of patients. And a lot of the impetus for asking you to change is rooted in economic arguments. And I think what we needed was some more fundamental examination of what truly the economics of oncology were. Secondly, is I've been following this literature personally myself for many, many years, and I would see these references to the cost trends in oncology, and I would look them up, and oftentimes the reference would be a New York Times article, or there was an article I was just reading in Health Affairs 3 months ago that mentioned that the spending on cancer care is going up 2 to 3-fold other healthcare spending, and I looked up the reference, and it was an IOM meeting, and IOM meetings are very good, but it's not a very crisp reference for exactly why the cost trends are what they are, and so I think that this issue was ripe for just fundamental examination for the issues. And the first finding is surprising to us. There was previous literature looking from the late 1980s through 2005 that suggested that the spending on proportional spending on cancer really wasn't going up any further, any faster than general medical inflation. But I thought that probably changed many years, a few years ago because of all the new therapies that we're using. Increased use of surgery, stereotactic body radiation, many different technologies. But I think one of the first surprising to me findings of the study is that when you look at per patient per year spending for actively cancer treated patients, it's really not going up at a faster rate than other general healthcare spending. And I think that's already an instructive finding.
And again, not to trivialize the fact that growing costs are critical, is today we spend almost 18% of our gross domestic product on healthcare, and as we know, our Medicare population today of 54 million will be 80 million by 2030. These are population cost-related issues that need to be addressed critically. But based on the information that we have here in both of these databases, we can see that growth in spending has been proportional.
Thank you. So now we're going to move to the second of the three results sections. This is about the component costs of cancer care. So at this point, we're going to be talking about that actively treated cancer population. So the next question we asked was, what is contributing to the cost for those actively treated cancer patients? There are 4 pie charts on this page, and what you'll see is the ones on the top are for the Medicare population, and the ones on the bottom are for the commercial population. They go from left in 2004 to right in 2014, so from the oldest to the most recent year of the study. And we've divided up the costs of treating these patients into sections. So you'll see inpatient hospital admissions, cancer surgeries, radiation oncology, other radiology, and then several types of chemotherapy, and that's what's bracketed together. Those 3 blue sections represent cytotoxic, biologic, and other chemotherapy and cancer medications. So what we saw were that there were increases in some of these sort of line items, cost centers, and there were decreases in some of them. So chemotherapy drugs were one of the areas that increased. They went from 15% to 18% of the total spending per patient per year in this population, in the Medicare population, and then in commercial it went from 15% to 20%. Specifically, biologic chemotherapies increased substantially. They went from 3% to 9% in the Medicare population, and from 2% to 7% in the commercial population. So sort of a multifold increase in those drugs, biologic chemotherapies, as a portion of the total spending on these patients. We did see decreases in some line items as well. So hospital inpatient admissions decreased from 27 to 24% of spending in the Medicare population, and from 21 to 18% in the commercially insured population. Cancer surgeries also decreased from 15% to 11% of total spending in the Medicare population, from 15% to 13% in the commercial population. So we did see some sort of shifting of what was contributing to that average per patient per year spending in these populations. We saw that the per patient per year trends varied considerably by service category. So you're seeing in the bottom row of this table the total cost trend for each population. So these are the same numbers that we saw before, that in Medicare, the costs over the entire period trended by about 36%. In commercial, they trended by about 62%. But you do see that some of these categories increase substantially more quickly than that underlying trend, and some of them increase more slowly. So we saw the hospital inpatient admissions, as well as that other chemotherapy line item, those were increasing at less than the total per patient per year trend. But some categories, again, including biologic chemotherapies, increased more than the total per patient per year cost trend over this period of time. We also noted that per patient per year Medicare trends were uniformly lower than commercial trends for almost every service category, the exceptions being subacute services, for which we see very little utilization in commercial patients, and radiation oncology, which was actually relatively low in terms of the total spending. We also saw differences in cost trends based on cancer type. So for the Medicare population, we saw, again, the underlying trend was 36%, but some cancers trended much higher than that. Blood cancer is one that stands out as being much higher than the underlying trend. We also saw prostate cancer increasing at a faster rate, whereas some cancers, lung cancer, pancreatic, and colon, trended at a lower than average rate for the Medicare population. For the commercial population, the 10-year trend was higher than average also for colon, blood cancer, breast, and prostate cancers, but it was lower than average for some cancers, again, lung and pancreatic cancers. So I'll turn it over to you.
So as we look at these results breaking out total spending per patient per year categorically, it was useful to try to understand what categories grew more than other categories. Not to anyone's surprise, the chemotherapy, cytotoxic chemotherapy bucket and the biologic therapy bucket grew during that time period, while things like hospitalizations decreased or at least didn't grow as fast as a rate as other spending. I think to put that in context, you really have to look at the disease distribution. And so that's why it was useful to look, I think, per patient per year by disease type to look at growth in both populations. I think Pamela's point about blood cancers outpacing the growth in spending as compared to other malignancies is a useful one, because I think of an area where we've had a lot of innovation in therapy is in blood cancers. And again, the data really just speaks to the spending, but as I seek to understand that and wonder what's happened in blood cancers in the last 11 years that has changed that, I can think to, I finished fellowship at MD Anderson in 2006, and at that time, when a patient was newly diagnosed with multiple myeloma, we would talk to them about having an overall survival average of about 3 years. And now, with the advent of many therapies that we can use in myeloma that are expensive, that certainly contribute to the cost of therapy for blood cancers, that overall survival has over doubled. So I don't tell patients with newly diagnosed myeloma that they have an average overall survival of 3 years anymore, but that survival advantage is correlated with this, this increase in cost. So it was helpful for me to understand categorically where that spending is. Obviously, chemotherapy is an important component of that cost growth. And I think, as many organizations seek to understand, the value, what is valuable spending, in each disease, where is the juice worth the squeeze? Those are different questions that we as an organization and as many organizations that help in oncology are trying to understand that value piece to understand sort of where that fits in the bigger picture.
Thank you. So for me, this section is a lot about perspective. If you look at, we have to look at that entire pie. The first thing that stands out is that, drug spending is an increase in cost. We need to take it seriously, but it's 20% of the pie. So if you could miraculously impact drug spending by 25%, you would decrease total spending by 5%. So if we're serious about bending the cost curve, if we really care about the costs, the only conclusion I think that makes sense from that is we have to look at everything in that pie. I think the other thing that is interesting is sometimes the negative findings are just as interesting as positive findings. And one example to me is the fact that treatment of colon cancer is kind of right at or a little bit below trend, depending on the Medicare or the commercial population. Colon cancer in the literature has been an example where cost of therapy seems to be escalating. Now we'll have to kind of understand what we're measuring. We're looking at per patient per year spending for colon cancer patients, and that's rising right along trend with the other spending. That it's not the same as total spending for a newly diagnosed colon cancer patient over their lifetime, because survival has gone from roughly 8 months to 22 months over the last 10 to 15 years for colon cancer patients. But if you just look at it year by year, spending on colon cancer is in line with spending for other malignancies. And I think that's interesting to me, at least, in somebody who's followed this literature, because that's always been brought out as an example of a place where, ostensibly the cost of care seems to be escalating more, an example for the escalating cost of care.
And I think to Dave's point, chemotherapy, biologic therapies are a small component of cost, not a small, they are a component of cost, of many costs that pertain to a larger system of care delivery. And so it is important to look at proportional growth. But really, as we seek to understand what can be solutions for better cost control, really those will likely be multifaceted to impact the entire system of care delivery.
Thank you. So before I move to the last section of results, there is one question here that, since we keep talking about it, I'm going to answer in the middle of the session, and that's how is cost defined in this study? So when we talk about cost, we're talking about cost to the payer and to the patient. It really represents the paid amount on the claims from the payer, as well as any patient cost sharing amounts that the patient was responsible for. So it doesn't mean the cost to the provider that you would put on your cost report. It means really what the payer is paying for the service and what the patient is paying as cost sharing combined. So this third section of results relates to chemotherapy site of service. So we looked at patients who were actively treated who had received some chemotherapy, which represented about 2/3 of all of the actively treated cancer patients received some chemotherapy. So this is showing you the volume of chemotherapy infusion claims based on the site of service, and we saw a substantial shift over this period of time. So the portion of chemotherapy infusions that were delivered in hospital outpatient departments as opposed to in a physician office setting increased from 15.8% to 45.9% in the Medicare population, and from 5.8% to 45.9% in the commercial population. That is oddly not a typo. Both of them ended up at 45.9% in 2014. In the Medicare population, we were also able to look at the portion of chemotherapy infusions that were administered in a 340B hospital outpatient setting. The only reason we're showing this for Medicare specifically is that in our databases, we are able to identify 340B hospitals in the Medicare data, and in commercial data, we aren't. So in the Medicare population, the portion of chemotherapy infusions that were administered in a 340B hospital outpatient department increased from 3% to 23.1%. So combining those two findings, what we saw is that in 2014, chemotherapy infusions that were given in a hospital outpatient department that was paid under that was part of the 340B drug pricing program accounted for 50.3% of all chemotherapy infusions in hospital outpatient departments. So it's not just that the hospital portion of chemotherapy, hospital-based infusions increased, but also the 340B hospitals increased as a percentage of those hospital-based infusions. Next, we looked at the per patient per year cost in patients managed in these different settings. So we divided the patients based on where they received their chemotherapy between 3 settings. So for the commercial, which is the graph on the bottom, you'll see the blue represents physician office administered patients, and the green represents hospital outpatient facility-based patients. In the top graph, you have those same 2 categories, with the exception of a third category is gray. That represents members who had their chemotherapy in a 340B hospital outpatient facility. So in the Medicare graph, those 2 categories are mutually exclusive. The green represents non-340B hospital outpatient facilities, and the gray represents 340B hospital outpatient facilities. We saw that the average annual per patient per year allowed cost for infused chemotherapy patients was significantly higher when the chemotherapy infusions were delivered entirely in a hospital outpatient setting as opposed to a physician office setting. So you can see that quite clearly in the graph. The blue bar is always shorter, and that's the physician office patient average cost. So compared to patients who received chemotherapy in a physician office, we found that those who received their chemotherapy in a hospital outpatient facility were more expensive in all of these populations. They were about $13,000 more expensive in the 2004 Medicare population, and they were about $16,000 more expensive in the 2014 Medicare population. And then among commercially insured members, they were $19,000 or 25% higher in 2004, and $46,000 or 42% higher in the 2014 commercially insured population. So those numbers represent how much more expensive an individual patient is overall if they're managed in a hospital outpatient department as opposed to in a physician office. This does not represent just the difference between the chemotherapy itself. It represents the difference in the total spending on these patients over the entire year. So this is the last point that we're going to go over, and I want to add some color to this finding because I think it's a little bit complicated. So in this analysis, as you saw, we found that patients were moving between settings essentially over time. Not necessarily the same patients, but that the breakdown of patients across different treatment settings was changing substantially. And so what we looked at was if we had assumed that the 2004 distribution of patients was maintained throughout each subsequent year, even if the actual cost of patients treated in those settings increased, we know in Medicare it increased at about 36%, and in commercial it increased about 62%. If we allow the cost of each patient to increase the way it did, but we maintain the site of service distribution at what it was in 2004, we can capture what the difference would have been if that site of service shifting hadn't happened. So over this 11-year period, what we're capturing in this model is the observed cost trends while we maintain the 2004 distribution of patients receiving chemotherapy in various settings. And so what we found is that in the Medicare fee-for-service population, the spending difference in 2014 alone, if chemotherapy infusion site of service had not shifted in this way, would be about $2 billion less than it was, right? So it would be $2 billion less than the observed amount. And what you're seeing in this slide is just sort of some sensitivity. So that's if none of the shifting had occurred. But let's say that half of the shifting from physician offices to hospital outpatient departments had occurred over that 11-year period, half of the observed amount, there would have been about a $1 billion decrease in 2014 costs for the Medicare population alone. So it's worth noting that this isn't a cumulative measure. This is simply the 1-year savings if this shifting hadn't occurred. And we did want to caveat this analysis by saying, we have assumed that the mix of patients that's seen in these different settings is not substantially different. Some might argue that more complex patients are the ones who are moving to hospital outpatient departments. We don't believe that the research substantiates that, and so we have assumed that the patient mix is approximately the same in those settings. We also modeled costs without considering regional variations or considering the behaviors of physicians that might lead them to maximize their reimbursement in the event of such changes as might have occurred to result in this change. So that is the end, I think, of this section of results. I'm going to go back so you can keep looking at it.
Sure. Thank you, Pamela. So, I think that this is a story that no one in this room is unfamiliar with regards to site of service shifts over time. It's frightening to see. I think that, it's been previously reported before that there's consolidation into the hospital systems. Obviously, because of the economic incentives to drive care towards the hospital outpatient department setting. But what I think this characterizes well is the magnitude of that shift over time, being at least 30% and up to 40%. And then more importantly, to understand what that attributable cost is, to what degree we can attribute increase in cost to the site of service shift. As we seek to have higher value care moving forward, it's not optimal to have differentials in payment by site of service alone if that cost can be avoided. So to see 30 to 40% increases in the cost of care that's attributable to site of service shifts alone, I think is very troublesome, and certainly an area where we could have improvement by not furthering consolidation or even improving upon it. I think it's useful too to characterize the total savings which would have incurred had no further site of service shifts occurred after 2004. So by taking the spends in 2014, the total spending in 2014 and distributing it over the site of service costs for the site of service distribution in 2004, because $2 billion in 1 year would be a tremendous amount of savings. So I think, as everyone in this room represents community oncology, we're not strangers to this story. We understand that community oncology is a high quality and more efficient way to deliver care to our patients. And we are the low cost provider on average in comparison to the hospital outpatient department. So I think that this data certainly supports what we have known and seen in prior studies in previous years, that this site of service shift has been very expensive. And I think, as we seek to bend the cost curve and control costs moving forward, I think it's useful to understand how important community oncology is as partners in that endeavor.
Thank you. So a few observations. I think this data, speaks for itself. And I think if we're serious about cost control and if we want to bend the cost curve, I think one thing we can all agree on, that paying more for the same thing just doesn't make any sense at all. Observation number one. Number two is that if you actually go back and look at that comparison of private office versus hospital outpatient for the commercial population and compare 2004 through 2014, you see that gap is increasing over time. Now, this data doesn't prove it, but it's consistent with the observation or the hypothesis that as more care gets consolidated under hospital outpatient, there's more negotiating power, more negotiating leverage with the insurers, and that private cost, the commercial cost of care is going up because of that. Now, our data doesn't prove it, but it's certainly consistent with that hypothesis. And I think this also just establishes that the site of care shift is an important cost driver. I think it's also just notable that, there's a lot of debate currently about the ASP system and maybe a perception or an argument that oncologists are treated too generously by the ASP system. I think one empirical, observation is that if that were true, we really wouldn't see the site of care shift that's happening. I think that would be hard to argue, why that, seeing, practices fail or migrate into different settings is not really emblematic of being treated too generously. So that would be my final observation for this section. And then lastly, I would just say, we've been looking at this data for many, many months, and it's still sinking in, and we're still sifting through it. And, I would just, I just ask the audience, please read this study, become familiar with it, read it a couple times at least, because again, the point at the beginning, so much of the arguments for changing how we do what we do, changing how we take care of patients, changing how we choose different therapies is rooted in economic arguments. And I think that becoming familiar with becoming familiar with that topic is an important part of learning about this.
Excellent. So I think that's the end of the presentation. There are some questions if you want to submit more questions, but if it's okay with you, do you want to go ahead and start answering some of these questions? So there are a couple of definitional questions. One is about the costs we're using again. Someone has asked if we're using standardized or contracted costs. The answer is that we're using the actual cost, so contracted, but that meaning what was actually paid for the service. So when you see a difference between the average cost of a patient in a physician office setting versus a hospital outpatient department setting, part of that might be a utilization difference, that they're receiving more services in the hospital outpatient department, and part of it will be a unit cost difference, that the payer is actually paying more for the same thing in the hospital outpatient department setting. So both of those things are contributing to the cost difference. I think there's a question for you folks that is pretty interesting, and it is, the real question is, what are we going to do about this? The hospitals continue to take in community oncology by backing them into a corner. The patient isn't choosing to move. They're at a practice that's being bought by a hospital. So what can we actually do about this, sort of knowing this difference? What is the actionable step that we can take?
I think that is, the big question and is the focus of so much around this meeting. I'll say that I think that many community oncology practices are partnering in real pilots to move forward to think about how to control costs in a meaningful way. Oncology practices worked with CMS and CMMI collaboratively on the development of the oncology care model. And then we have many practices in the room that are participating in that pilot. As I'm a partner in Texas Oncology, we have a productive pilot with Aetna, productive pilot with United Healthcare. Bruce Gould had his pilot with United Healthcare that was published. And I think that those kind of collaborative, system-wide solutions are going to be important moving forward, and we'll have to look at the evidence to see what's effective. I think that as we see unfortunate policies move forward, like the ASP experiment that only are a blunt instrument to impact one arm, the drug delivery arm of the care delivery system, I would have concerns that that's not going to be meaningful to improve the quality of care delivery and control costs in the long run, but have natural consequences to further consolidate care to the hospital system. I think that as community oncology has been leaders, we've been leaders in innovative payment reform contracting models, that seeing us move faster towards escalation of approval of advanced alternative payment models through like OCM with the patient-centered medical home or PCOP, that incorporate whole systems of care delivery changes in addition to pathways that facilitate appropriate utilization of drugs, because really it would control costs to facilitate underutilization, but it's not the right thing to do for patients. That way we can have, efficacy, toxicity, and models of comparative effectiveness built into systems of care delivery. So that's my answer.
I think that's a great answer. I think the first thing we can do is understand the problem. We can't fix a problem if we don't understand it, and I think there has been a lot of misunderstanding about this. The second issue is that we have to divide up what parts of the cost curve are modifiable and which parts are not modifiable. But there are certain demographic shifts that are happening. That we have an aging population. As you get older, you're more likely to unfortunately develop cancer. And that's not a modifiable part of the cost trend. I think that we need to look at that entire pie of everywhere we're spending money and try to create a system that encourages responsible spending. I think Deborah just outlined many of those things, and I think that the current slide speaks is as clear as day that the site of care shift just needs to be addressed. But the people who can best address that are the policymakers and the commercial insurers, and they can do it with our partnership and our encouragement. I think the models that Deborah just listed are tremendous examples. I think Medical Home, the Come Home Project are examples. I think I would say there's only a few examples of people looking at that cost curve, looking at the pie chart, and saying, okay, what are the parts of the cost curve and the cost pie that I can control, and accounting for that. And I think Come Home, I think Medical Home are examples of one of the few examples where people are actually accountable for the cost that they're contributing to the system.
And I think that that's a collaborative answer that practices have to engage in. As we sit here a month out of the CMS putting up the ASP experiment, one can't help but contrast that policy intervention. And, I kind of feel like taking away any compensation for financial incentives for prescribing is sort of something that's been done. As we look at the pilot Bruce Gould's practice did with United Healthcare, where they took away financial incentives for prescribing chemotherapy drugs to see if chemotherapy drug costs would go down, in addition to other things that impacted the system of care delivery. And what that pilot, the results of that pilot, which were peer reviewed and published, showed that actually costs went up from about $7 million to $21 million in cost of chemotherapy. So you take away the financial incentives, there's innovation, and there's some more spending on chemotherapy, while at the same time, total costs went down by about $30 million because of all of the other changes in the care delivery system, which are so meaningful. So again, I think that you can't just look at, my pinky to know me. You can't just look at drug delivery to look at the whole system of care delivery. It's a complex system, and I think, we as community oncologists need to continue to step forward to be part of that solution.
So the little clock in front of me is telling me that we've overstayed our welcome by about 5 minutes. But if you would like to know more, there is a full copy of this report on the COA website. And so feel free to reach out to any of us. I think we'd all be happy to talk to you more about this study and the mountains of data that we have and are still sort of interpreting in an ongoing way. So